Myself, Dr. Deepal Prajapati, Assistant Professor in Cardiac Anesthesia, working in UN Mehta Institute of Cardiology and Research Center. Objectives of my lectures are review prenatal and postnatal formation of the cardiovascular system, review the fetal, transitional and persistent fetal circulation, review the relevant impact of oxygen on newborn resuscitation. Embryologic formation of the cardiovascular system. Here, at the day 21, the heart tube consists of truncus arteriosus, bulbus cordis, ventricle and atrium. At day 23, the looping of heart tube begins, and at the day 27, the heart is almost ready for the circulation. Postnatal cardiovascular development. Neonatal myocardium. The neonatal myocardial contraction is weaker than in childhood or adulthood because of less contractile elements, more connective tissue, myofibrils are less organized, insufficient calcium utilization, and the other minor reasons are contractile protein immaturity, insufficient energy storage and utilization, immature cellular regulation of the action potential. Neonatal myocardium. Traditionally, it was thought that the neonatal cardiac output is almost entirely heart rate dependent. However, neonatal hearts do respond to alterations in preload and afterload, but less so than in adult. But the neonatal Starling curve is narrow, meaningless ability to alter the stroke volume based on loading conditions. So, overall, high metabolic demands of the neonates require heart to operate at near maximal capacity at most times. Neonatal heart operates at near maximal capacity at most times. Thus, the stressors like hypoxia, anesthesia, they risk rapid decompensation in neonates. Many anesthetics reduce oxygen consumption, but overall myocardial suppression and heart rate lowers under anesthesia risk, likely worse in settings of acute or chronic hypoxia. The neonatal and fetal heart does respond to sympathetic stimulation. Sympathetic nervous system is immature at birth but is mature by late infancy. The parasympathetic innervation dominates there at time of birth and exaggerated vagal responses to various stimuli. Fetal circulation. The hypoxic environment. Fetal circulation is relatively hypoxic compared to the mother and after birth. PaO2 of umbilical vein blood entering the fetus is 30 mm of mercury. PaO2 of the blood entering to placenta is 16 mm of mercury. Presence of fetal shunts allow best utilization of the limited oxygen to fetal tissues. The three fetal shunts working in the are ductus venosus, foramen ovale and ductus arteriosus. Now, ductus venosus. Umbilical venous blood from the placenta has high velocity and PaO2. Ductus venosus is crucial to allow this fast oxygenated blood to bypass the liver. 50% of the umbilical venous blood passes through ductus venosus and the remainder is distributed to both the lobes of the liver. The blood preferentially streams to the coronary artery and brain. This is shown in the next slides, several slides. Fetal circulation. Course of the oxygenated umbilical vein blood bypasses the liver via ductus venosus, mixes with IVC. From there to Eustachian valve shunts towards the PFO. From there to LA, to LV, to aortic valve, to aorta and to coronary and carotid arteries. Therefore, oxygenated blood from the umbilical vein perfuses the brain and coronary arteries by shunting across the liver via ductus venosus and shunting across the right heart via foramen ovale. See, here is the diagram. The umbilical vein via ductus venosus, blood passes through Eustachian valve to patent foramen ovale, from there to LA, from there to LV, and LV to aorta, and aorta to coronary and carotid arteries. Desaturated SVC blood from the fetal brain takes a different course. like SVC, from the SVC to RA, from RA to tricuspid valve, from tricuspid valve to pulmonary valve, ductus arteriosus, and descending aorta, and from descending aorta to back to placenta for oxygenation. Here is the slide for that. See, the deoxygenated blood enters from the SVC to RA, from there to it passes through tricuspid valve, from there to RV to pulmonary valve, and from there to patent ductus arteriosus. Most of the blood passes through descending aorta and very little amount of blood goes to pulmonary artery. Here is the figure showing oxygen saturation of the fetal blood. See, in the umbilical vein, it is carrying 80% oxygenated saturated blood. It enters liver and passes through ductus venosus. It is carrying 65% of saturation, which enters through eustachian valve, and from there to foramen ovale, and from there to LA, LV, and from there to carotid and coronary arteries. It mostly supplies the upper part of the body and brain and other important vital organs. So, mostly it is maximally oxygenated blood, 65% oxygenated blood. So, now the blood coming from the IVC and SVC carrying 25% of saturation, it mixes in the RA, from there to tricuspid valve, to RV, to PA. Here it becomes 50% saturated blood, and from there to pulmonary artery to through PDA, it goes to descending aorta. Here a small amount of oxygenated blood comes and mixes with it, and it becomes 55% saturation, which goes to rest of the body of the part. Now this is the figure showing combined cardiac output of the fetal blood from the right ventricle. Here the blood coming from the right ventricle, 66% of the cardiac output, it goes mainly through pulmonary artery, consisting mainly 59%, where it enters the descending thoracic aorta. There 10% of the cardiac output from left ventricle mixes with it, and it becomes 69%. Then it goes to rest of the part of the body, and only 7% of the total cardiac output from right ventricle goes into pulmonary artery. Now this is the figure showing combined cardiac output of the fetal blood by left ventricle. Here the blood entering from the ductus venosus through eustachian valve to foramen ovale, and from there to LA, to LV, to aorta, and from there to other part of body. Here from LV, LV ejected 34% of the blood. From there 31% of the blood enters aorta. From there it gets most of the blood to brain and coronary arteries and upper limb and most of the parts. 10% of the cardiac output only that mixes with descending thoracic aorta. The hypoxic environment. Fetal oxygen delivery is maintained in the relative hypoxic environment because of high cardiac output, high hemoglobin, greater oxygen affinity of the hemoglobin F for enhanced oxygen uptake at placenta, lower pH in fetal organs for enhanced oxygen release at the tissue level. Now the transitional circulation. The transitional circulation means transition from fetal to normal adult circulation. It begins when umbilical cord is clamped and lungs are inflated. Clamping the umbilical cord causes removal of the low resistance placenta. It causes increase in SVR, which causes increase in left heart pressure. Now breathing after birth causes expansion of the lungs and increased PaO2, 8 to 10 times drop in pulmonary vascular resistance, which causes significant increase in pulmonary blood flow. The cord clamping and lung inflation causes increased SVR and decreased pulmonary vascular resistance respectively. This causes increased pulmonary blood flow and increased blood return to the left atrium, which causes increase in LA pressure, then RA pressure, and so closes the flap like foramen ovale. Functional closure of the PFO occurs quickly but anatomic closure usually requires week. Usually in 25% of adults, it remains open. The ductus arteriosus remains patent in utero due to hypoxia, mild acidosis, and placental prostaglandins. Removal of these factors after delivery causes functional closure, with anatomic closure occurring weeks later. Persistent PDA often occurs in premature infants with lung disease. Indomethacin, via its anti-prostaglandin action, can be used to try and close a PDA. Before anatomic closure of the PDA and PFO, pressure of right atrium is larger than the pressure of left atrium, which causes reversal of the fetal circulation, that is right to left shunt and cyanosis. Hypothermia, hypercarbia, acidosis, hypoxia and sepsis can all cause a reversal to fetal circulation. Now, ductus venosus. Flow through ductus venosus stops immediately when the umbilical cord clamped. Full irreversible closure occurs in 1 to 2 weeks. Fibrotic remnant is called ligamentum venosum. Now, persistent fetal circulation and persistent pulmonary hypertension of the newborn. Persistent fetal circulation, it means right to left flow across the foramen ovale and or ductus arteriosus as in utero. There are two primary causes for it. One is congenital heart disease and the second one is persistent pulmonary hypertension of the newborn. It means persistently high pulmonary vascular resistance after birth. Most common cause is parenchymal lung disease caused by mainly meconium aspiration and respiratory distress syndrome. The other causes include sepsis, alveolar capillary dysplasia, surfactant dysplasia, severe lung hypoplasia. High pulmonary vascular resistance limits pulmonary blood flow and left atrial filling, causes high RA pressure and keeps the PFO open. High PVR, hypoxia and hypercarbia keep the PDA open. Thus, combination of right to left shunts at PFO and PDA as well as poor alveolar ventilation causes hypoxemia. Treatment ranges from the simple supplement of oxygen to ECMO, that is extracorporeal membrane oxygenation. Now, PPHN and anesthesia care. The goal for it is to maintain the adequate oxygenation, myocardial function and systemic perfusion. For it, avoid worsening PVR, so avoid hypoxia, acidosis, excessive PEEP, atelectasis and catecholamine release, which usually occurs in light anesthesia. Increased FiO2 causes pulmonary vasodilatation, but hyperoxia can be harmful to newborn. Maximal pulmonary vasodilatation occurs at relatively low oxygen levels. Thus, titrate oxygen to lowest acceptable amount with goal of PaO2 of 60 to 90 mm of mercury. Maintain normocapnia, use inhaled nitric oxide if required, ensure adequate systemic blood pressure, for that use inotropes as needed. Now, newborn resuscitation and the use of oxygen. Newborn oxygen saturations. Transition to extrauterine life causes marked increase in oxygen saturations in terms newborns. Normal saturation in term infants is as follows. At 1 minute it is around 60 to 77%, 2 minutes 65 to 84%, 3 minutes 71 to 90%, 4 minutes 78 to 94%, 5 minutes 83 to 96%, at 7 minutes almost 90 to 97%, and at 10 minutes it's 94 to 98%. Now, newborn resuscitation and potential effects of oxygen. Newborn hyperoxia can be toxic and lead to irreversible injury. One breath of 100% oxygen decreases minute ventilation. Longer duration can lead to chronic lung injuries. Resuscitation with 80% oxygen in delivery room decreases cerebral blood flow for 2 hours. Exposure to high FiO2 for 3 minutes or longer may be associated with increased risk of childhood cancer. Can lead to oxidative stress and production of oxygen-free radicals lasting at least 28 days. Animal studies provide evidence of apoptotic cell death in brain after various exposure to increased FiO2. Effects are slightly greater in premature compared to full-term newborns due to lack of adequate protective antioxidant levels. Because insufficient or excessive oxygenation can be harmful to the newborn infant, recommendations exist for newborn resuscitation. For that, use oximetry. Assessment of color is unreliable. For babies born at term, it is best to begin resuscitation with air rather than 100% oxygenation. Administration of supplementary oxygen should be regulated by blending oxygen and air, and the concentration delivered should be guided by oximetry. If the heart rate is below 60 after 90 seconds of resuscitation, the oxygen concentration should be increased to 100% until recovery of a normal heart rate. Although resuscitation of a newborn should be initiated with room air, relative hypoxia can be detrimental and must be avoided. So, preductal saturation, that is right upper extremity saturation, must be used to guide targeted saturation levels during the delivery room, as I stated below. Like 1 minute after delivery 60 to 65%, 2 minutes 65 to 70, 3 minutes 70 to 75, 4 minutes 75 to 80, 5 minutes 80 to 85 and 10 minutes 85 to 95. These are the goals for delivery room, not for operating room. For operating room, the normoxia is the goal, that is more than 94% of saturation. Avoid both hypoxemia, which increases the risk of mortality, and hyperoxia, which causes ROP, especially in preterm. Beware of overventilation. So, for that, a PCO2 of 40 to 50 is beneficial. It causes decreased lung injury, increased cerebral blood flow, increased oxygen unloading at tissue level. Thank you.